Right. Dear colleagues, my name is Audrey Kok. I'm a specialist physician in South Africa, and it gives me great pleasure as the president of the International Society to do this lecture at the invitation of Professor James Guterres. I congratulate you on an excellent program, and I trust that all of you have had an enjoyable time so far this morning. I'm going to be discussing a little bit about diabetes and the new treatment options available to us, and some decisions about what should we use, how, when, and why. These are my disclosures. So if we look at diabetes, this is a study that we did in South Africa, where it showed very clearly that our diabetic control is very poor. Our HbA1c level of 9%, and this was in our public sector, as well as the private sector in South Africa, they are the two groups, have shown that we have very poor control and we're not getting to the target HbA1c levels that we should be aiming for. So we have looked at what the ADA and EASD guidelines have considered at the recent Congress in in Stockholm, and they discussed really what should be the goals of care. The most important goals of care is to prevent complications, first of all, and to optimize the quality of life for the patient. And there are various aspects that will come into play when we have to consider all of these. We have to look at the person, we have to look at what the impact of the choice of treatment will be, what was the management plan, how do we agree with the patient on the management plan, and then how do we continue to support the patient when we are doing this. And I think this has really been a new approach to how we should be changing our management of the patients with type 2 diabetes. They've also highlighted in the new consensus document two major aspects of treatment. The first being that there is a very real risk of hypoglycemia that can affect the patient both from a physiological point of view, but also the quality of life. And these hypoglycemic events may definitely lead to a cognitive dysfunction. There can even be brain damage as such, vascular events, for example, arrhythmias, the patient's symptom unawareness of hypoglycemia, and quality of life generally, because these can often result in the patient having to be admitted to a hospital if they have a severe event. So if we look at this as one of the aspects, when we look at the new classes of agents, we do have choices now of medication that has a much lower or a negligible risk of hypoglycemia, as you can see on the right-hand side, especially the SGLT2 inhibitors, GLP-1 receptor agonists, DPP-4 inhibitors, metformin, and the thiazolidinediones. And in the past, what has been used more up to date has been sulfonylureas, because they've been more affordable, and of course insulin, which works very well, but has a very inherent risk of hypoglycemia. We also know that the diabetic patient battles with obesity, and it's mainly the visceral fat distribution that is problematic. This fat is not inert, it's not without a problem. It causes a high risk of thrombosis. It has a high risk of hyperlipidemia and associated metabolic factors that increase the vascular risk to the patient. And this is an important fact because this has really influenced how we view the management of our patients with type 2 diabetes, because one of the important aspects then has to be to consider weight loss. So weight reduction as a targeted intervention is another of the consensus guidelines that the ADA and EASD have come up with recently. So weight reduction per se, apart from glycemic improvement, is an important aspect. And they're looking at a 5 to 15% weight loss as a primary target for many patients living with type 2 diabetes. If it can be a higher degree of weight loss, it's even better because there's even more metabolic improvement. And very importantly, that weight loss can improve risk factors for cardiometabolic disease. And this is really something that's become a much more important aspect of our management of these patients. We know also from the UK PDS that some type 2 diabetes therapies are associated with weight gain. And of course, over time, the sulfonylureas, apart from this problem, lose their efficacy because of the beta cell dysfunction that follows. Insulin itself, again, can be associated with huge weight gain. And now we have agents that have the ability to facilitate weight loss. And so with weight loss, you improve the cardiometabolic factors that come into play. It's become a much more complex disease to consider. And if we look at this schema where we look at all the aspects and how the glycemic targets have really expanded as our understanding of the disease has improved, it gives us a bit of an idea of how tremendous the complexity is when we make decisions on our patients, and specifically what would be the next best treatment for that patient in front of you. We know from previous trials that our previous treatments, unfortunately, did not give us the benefit that we thought it would, so that although there was better glycemic control, it did not impact on mortality. It also didn't improve the macrovascular risk, which is, of course, a very important aspect because patients don't die from a high sugar, they die from the cardiometabolic complications of type 2 diabetes. And we saw this very clearly during the COVID pandemic because our diabetic patients with a higher risk of inflammatory response really did much worse during the COVID pandemic. And we had a high mortality rate in these patients. When we look at previous interventions, we know that metformin and the associated management with more intensive control in the UK PDS study showed that the quicker we actually intervened, the quicker we would have the benefit of a legacy effect. And this is especially on macrovascular outcomes. And it took a long time for the UK PDS study to show this benefit. It's not something you're going to see within a day or two or a year. It happened over time that as you improve glycemic control, and this is just in agents at that stage that were really old therapies, whereas today we have so much more exciting ways to treat our patients. So that's been the story. We have to try to control our patients early on, get them to a target that is achievable, but use medications that doesn't have a risk of hypoglycemia, that have a durability of action, and also that have a weight benefit. So no weight gain, it must either be weight loss or then significantly no weight gain. That's a very important aspect. So I thought I'd put in a patient that I think would be the type of patient many of us would have seen, a 59-year-old patient, diagnosed type 2 diabetes 8 years ago, initially controlled with metformin, and then a sulfonylurea was added. And when deterioration of control was seen, they added a basal insulin, in this situation, glargine. But unfortunately, you gain weight. And despite exercising the patient, even though he's a non-smoker, non-drinker, he was gaining weight. And looking at his blood results, he has evidence of an HbA1c of 9.1%. And you can see on the left side that his fasting glucose readings are still all elevated. And these reflect then in an elevated HbA1c. And together with that is poor blood pressure control. His weight is a problem with a BMI of 33 and elevated lipids with a bad HDL level and an LDL that is not at target. So when you sit with this patient in front of you, what would you consider next? Can you use a DPP-4 inhibitor? Should we use an SGLT2 inhibitor? Can we use a premix insulin? Should we use a GLP-1 receptor agonist or combination therapy? So many questions as to what would be the best to use in a patient such as this. When we look at these groups of agents, the DPP-4 inhibitors, the GLP-1 receptor agonists, and the SGLT2 inhibitors, we have various aspects to consider. So we know from the DPP-4 inhibitors, they have a neutral effect on the major cardiovascular risk factors, but they have the benefit that they don't cause hypoglycemic effects. They have a weight neutral effect, and they also have the benefit that they can be combined very easily with metformin, and they are not dependent on beta cell function. They also work on glucagon. And the second group being the GLP-1 receptor agonists, they long-acting. The long-acting ones, they have significantly improved major cardiovascular events. And I'll show you some of the data just now. And then the SGLT2s, which showed even better reduced MACE with secondary prevention and reduced hospitalization for heart failure with renoprotective effects. So if we look at cardiovascular disease in diabetes, there are various ways in which the patient with diabetes can be affected. And it shows very clearly that whatever vascular bed is affected, whether it be a stroke or a heart attack, heart failure, or peripheral arterial disease, that in diabetes, unfortunately, the patient's outcome is even worse because of the diabetic effect and the fact that we have, unfortunately, this high inflammatory risk in the patient with hyperglycemia that is uncontrolled. And if you look at those results, you can see very clearly why this is such a challenge then when we treat these patients. So when we go through some of these, I'm just going to mention a little bit of the trials. We know the DPP-4 inhibitor metformin combination. It works on the two arms of beta cell dysfunction, glucagon, improved hepatic glucose overproduction, and insulin resistance. And just some of the initial studies that showed very effectively that the combination of these agents had a much more beneficial effect in HbA1c reduction. And remember, these initial studies were done to show efficacy, and they were done versus usual therapies such as sulfonylurea. The other benefit was that there was no bad effect from a cardiovascular point of view, remembering that the initial cardiovascular outcome studies were done specifically to make sure that these agents were safe to use and that there was no risk from a cardiovascular point of view. So they didn't show superiority, but they did show us that they were safe to use in a patient with vascular disease. Also remembering that they work on the GLP-1 system, but just by inhibiting the enzyme rather than increasing the GLP-1 itself, as does the GLP-1 receptor agonist. What was interesting from the TICOS study was that there was a delay in the use of insulin in these patients. So if you looked at it, in some patients, they could delay up to 4 years. Now, this was just with the agent combined with metformin, and initiation of insulin could be delayed quite significantly, which is another very important aspect, because it does mean that we can actually avoid having to do excessive amounts of insulin in these patients. Now, looking at the GLP-1 receptor agonists, and these would be the liraglutide, dulaglutide, semaglutide, because these are the longer acting agents. It's very important that the shorter acting agents, which are the exendin-based, exenatide, for example, did not show the same benefit. And this is a very important distinction to be made. So when we look at these agents, the LEADER trial showed us that apart from the efficacy in getting the HbA1c down, there was a definite benefit in weight loss. And the weight loss was maintained over time. Now, remember, this study was done for cardiovascular safety, as well as then seeing what benefit these patients could arrive at by using a GLP-1 receptor agonist, liraglutide. The second thing is that it showed a 13% improvement as far as the primary outcome of major cardiovascular events is concerned. And again, it was also seen to be a benefit that was maintained over time. It showed that renal impact of this agent was also demonstrable. And this was not at the onset evaluated at every visit. As you can see, it's a skipped approach, depending on when the patients did see their group. And you can see that the benefit again was maintained over the 54 weeks of the trial. Very important aspect, apart from the weight benefit, was that there was no hypoglycemia or very little hypoglycemia unless the agent was combined with insulin or if the sulfonylurea was not stopped for any reason. So the benefit from a hypoglycemia point of view was absolutely crucial. We know from the dulaglutide studies, and I've just shown you the summary of the award trials, that these agents, and this is dulaglutide used also in primary prevention, had the benefit that it actually prevented disease in these patients, de novo. This is just a summary of the head-to-head studies showing that in the light blue, in all of them, the HbA1c reductions were significant. And this was again just in a study population to show the efficacy. And similarly to dulaglutide, like liraglutide and semaglutide, these agents didn't show hypoglycemia and there was a weight benefit, apart from the cardiometabolic benefits and the renal benefits that we now know is equally important. I didn't show all the studies because I know you have seen some of them. I've just tried to highlight the important ones that should impact on how we manage these patients. This is just another patient, Mrs. JP, 62 years old. She was diagnosed when she presented with a heart attack. She underwent coronary angioplasty with a stent. She had a normal cardiac function. Her initial hypoglycemia was managed with insulin, and she was discharged on metformin with gliclazide, MR, which would be the same as glimepiride. I'm not sure which you have available in your country. And unfortunately, she has renal dysfunction because she has been hypertensive for a number of years. And if we look at her results, it shows very clearly HbA1c is not yet at control, 8.2% versus 8.9%. And we absolutely have to get this patient to at least below 7%, but safely, because now she has renal dysfunction. So a very important aspect to consider in her treatment. So initially, just with the severe hypoglycemia, of course, she was treated with insulin, but you can start the oral agents at the same time and then slowly reduce the insulin as the patient achieves good control. And again, in this patient, what to do next? You have to consider the renal dysfunction. She's had a myocardial infarction, so there's a cardiac risk. And the poor control is important because that, again, is part of what has to be done as far as considering the next option in her treatment is concerned. So when we look at the SGLT2 inhibitors, there are various ones. I've not listed all of them, just some of the major ones in some of the trials that have shown the cardiovascular benefit. And these agents work on a system where they actually work solely on the kidney, and they have the effect that they filter glucose and they stop the reabsorption of glucose from the kidney so that you excrete the extra glucose in the urine. And by doing so, they also lose salt for each glucose that is lost, which then gives you the benefit of the reduction of heart failure risk in these patients. And there are various metabolic factors, which, again, this lecture is too short to consider. But again, we know that the trials have shown us how these agents have improved our patients' outcomes. The first trial that really showed the benefit was the EMPA-REG study with empagliflozin, and it showed at a very early stage that the primary outcome could be impacted with 14% risk reduction, 6.5% absolute risk reduction with empagliflozin versus placebo, which was usual therapy. And this was again maintained over the period of time of the trial. We've had these agents around for a few years now, so they're not new anymore. And we've become familiar with using them. And we've seen that what was seen in the studies actually did translate into real life as well. And we see the same benefit in our patients. Cardiovascular death was even more significantly impacted. And if you look at a 38% risk reduction, again, starting very early and being maintained, and the benefit showing an amplification over time, it is very clear that these agents have a significant benefit to give us a better outcome for our patients with diabetes and cardiac disease, as well as renal disease. The other impressive finding was that these patients now lost weight. We know from one study where they did DEXA scans that the weight loss wasn't due to dehydration, as some would suggest, because you're losing salt with glucose, but rather as a result of fat loss. And we know that these agents have also now been investigated in non-alcoholic fatty liver disease, where we also see a huge benefit as far as reducing this very important possible complication in our patients with type 2 diabetes. And when we look at hypoglycemia, again, because they work independent of the pancreas and they only work on the glucose that is in the body, hypoglycemic risk is very low, if not negligible. So again, we have these two aspects that have given us a huge benefit in our patients with type 2 diabetes. Low risk of hypoglycemia and a weight benefit. More importantly, the cardiometabolic and renal benefits that is illustrated with these agents. The DECLARE TIMI trial was done in a patient with a broad cardiovascular risk population and clinically important risk factors. This was done over 17,000 patients with dapagliflozin. And the DECLARE study again showed patients that had renal dysfunction and multiple risk factors, as well as established cardiovascular disease. And these studies just continue to show more and more evidence of the benefit of these agents as far as cardiovascular risk is concerned. When we look at the renal outcomes, hospitalization for heart failure, major cardiovascular risk, multiple risk factors, in all of these, you can see that the SGLT2 inhibitors gave a significant benefit across these studies done with the SGLT2 inhibitors. And again, I have not included all the recent trials, but there are renal studies that have shown that in patients even with no diabetes, that there's a benefit in protecting the kidney. and in patients with no diabetes, but with vascular risk factors, with vascular disease, such as cardiometabolic disease, that those patients, again, derived significant risk from using an SGLT2 inhibitor. And in patients with heart failure, where there's a definite intervention with SGLT2 inhibitors, there was an even higher indication for the use of these agents in these patients. But we're looking at only the patients with type 2 diabetes. And in this group, again, there are multiple reasons why these agents make sense to use as far as treating the patient with diabetes is concerned. And most importantly, that legacy effect, where early treatment can result in long-term benefit for the patient as we manage their diabetes. If we look at the KDIGO guidelines and the way that the renal outcomes have now been improved, this is done with dapagliflozin, we can see that there's a clinically meaningful improvement in these patients where there has been renal dysfunction, and this can be even in patients where there is no diabetes present. Of course, in diabetes, especially long-term diabetes, patients with heart hypertension or other cardiovascular risk factors, this would be an especially at-risk group, and therefore so important that this must be considered and monitored. For example, the patient that I showed with an eGFR of 48, which already puts her in a high-risk KDIGO classification. So at that stage, you can intervene and improve the deterioration of that patient's renal function and not only treat their diabetes more effectively and safely. If we look at the ADA EASD algorithm, there's so many questions. Can we actually afford it? And there's a huge movement now that we should actually look at an SGLT2 GLP-1 agent in the patient with obesity, with cardiovascular risk factors, with renal dysfunction, with atherosclerotic cardiovascular disease, that an SGLT2 inhibitor or a GLP-1 receptor agonist should almost be your first treatment and not delayed until these complications have already occurred. So it is a difficult one because they are more expensive, they are newer agents. And so we are at a situation where we have to try and see in the long term what would benefit our patients best. Can we target obesity? Yes, we can. We haven't even spoken about tirzepatide, which is a new agent that's coming through and showing great benefit and will probably be available in many markets soon. Cardiovascular disease, atherosclerotic cardiovascular disease, where we know that the GLP-1 receptor agonists have had the higher benefit, and we know that the SGLT2 inhibitors also come into play in preventing these complications. What about heart failure, where we know that many patients with type 2 diabetes can develop not only cardiomyopathies, they can develop vascular disease of the coronary vessels. And so heart failure in the diabetic patient is particularly associated with a poor outcome. Renal impairment because of the longevity of their diabetes and how this may impact on their life. And then really, do we still aim at diabetic control? And absolutely, because a patient with an HbA1c of 7% or even better, 6.5, where we can address all these risk factors early on and where we can establish that legacy effect of good control, does make logical sense if we're treating our patients with type 2 diabetes. Looking at costs, we know that initial therapy may have a cost, but we know that acute complications such as hypoglycemia and the risk of hyperglycemia with all the associated complications that may occur is a very real factor to consider. But the biggest cost lies with long-term complications. And this is where we are trying to impact on our patients with type 2 diabetes. So when we do that initial costing, we have to consider what we are preventing in the long run and those costs that escalate over time and really actually make the diabetic patient much more expensive over time if we don't do that initial therapy well enough. So in conclusion, we have to try and see if we can treat our patient to an HbA1c target for your individual patient, making sure that your patient and the care of your patient is central and that you will really do the best for that individual patient as you consider what would be the best options for them. You have to consider all aspects of the patient's care when escalating treatment. And very importantly, you have to escalate if the patient is not at target. Avoid clinical inertia because this delays treatment, it delays escalation of treatment, and you avoid, in the long run, better control, which can control and avoid complications. If we look at important comorbidities, hypertension, obesity, the risk of hypoglycemia, hyperlipidemia, stopping smoking, all of these factors come into play. And I think finally, always discuss the options with your patient to decide what is best for them, what they feel comfortable with, what they can comply with, and what can really give them the best longevity, the best quality of life. Thank you very much. I'm sure there may be questions. I'll hand over to the chairman.
Sí, la doctora.
I can't hear any questions at the moment.
I am Dr. Garcia. In your opinion, what's your point of view about metabolic surgery or bariatric surgery? Because much of physicians have a preoccupation because a lot of patients turn to surgery to resolve this, to change the body weight. And all of these patients have obesity and overweight.
Yeah. So absolutely, thank you for the question. And it's an absolute brilliant option. I just think that if you look at when the studies were done, most notably the SAS study from Sweden and the Scandinavian countries, none of these new agents were actually in use. I'm always concerned about the long-term effect of bariatric surgery. We have seen patients with complications in the long run, and I think it does speak to where it's done and the expertise of the unit. And if this is available, it is, in my country, quite a costly operation, but it works. And it works very well, but your patient has to be prepared very carefully. And I think the different options of bariatric surgery, of course, we know that the Roux-en-Y malabsorption type surgery has the best long-term cardiometabolic benefit. So it is a very real option. Unfortunately, that at some stage, you cannot unoperate. So once the operation is done, you can't reverse it. And this has always been the problem that in the long run, we've seen patients with hypercalcemia, renal dysfunction. And so I think it is one of the options to be considered very carefully when all other options have been exhausted. So thank you for bringing that as a possible option. Thank you.
¿Alguna pregunta adicional? ¿Sí?
Buenos días. Quería comentar en relación a los inhibidores de la SGLT2. Vemos nosotros que hay una mejoría significativa en muchos factores, tanto renal, cardiovascular, mejoría de la hemoglobina glicosilada. ¿Por qué no considerarlo ya como el primer tratamiento para pacientes con diabetes?
La traducción que ha podido hacer la pregunta a la doctora Koch.
Can somebody just translate for me? Sorry, I didn't understand. I couldn't understand the question. Sorry, I can't understand Spanish.
Vemos que los inhibidores de SGLT2 tienen muchos beneficios, múltiples beneficios, renal, cardiovascular, a nivel de mortalidad en sí. ¿Por qué no utilizarlos ya como medicamentos de primera línea en este caso?
Can somebody just interpret for me, please, in English?
I wonder whether you're receiving, doctor, please. Are you receiving? The question is with respect to SGL2 inhibitors. Wouldn't they be considered as first choice therapy, knowing that they have so many beneficial effects, as you have shown in your lecture?
Yes, and I think this is what the ADA and the EASD consensus guideline is considering. And, you know, we are looking at, when we look at the studies, they were done with patients with established disease. We don't yet have primary care where we know that these benefits occur if there is a disease present. We would love to be able to use them in every patient. But again, there's a cost factor. So I'm not sure in different countries, of course, this is not as much of a problem as in others. In my country, they are still costly, and the GLP-1 receptor agonists, again, also very costly in comparison to generic agents such as sulfonylureas and metformin. DPP-4 inhibitors are more affordable, and it comes to this point about initial therapy and what would give you the best long-term outcome. And I would agree with you, these agents look brilliant to be able to address all these risk factors. And for me, the most important one is really the weight loss. And you know, we've seen it in patients where we've used these agents that they've had really good weight loss and it's been maintained. So there are some side effects to the agents, and that has to be considered. We know about the genital infections, and these can be easily treated. But I think it is very important that we have a perspective, and that's why I think it's so important that we look at our patient, discuss with them what they can afford, show them what is possible, what is indicated, and then consider what would be the best agent for them. We've also seen that, that we have over time needed more treatment sometimes to get the HbA1c under control, so that even patients on the SGLT2 inhibitor with metformin may need extra therapy to get to an adequate diabetic level and HbA1c that is acceptable. So it's not necessarily that they tick all the boxes, but they definitely tick many of the boxes. So yes, thank you for that question.
Would you comment on a patient that has heart failure with preserved ejection fraction? The benefits of these agents apparently hold on this group of patients. Do you think that?
Yes, so I think, you know, the studies have now shown us that it really goes across the spectrum of the disease of heart failure, from very severe impaired ejection fraction, and that you have the ability to intervene on these patients. We've also seen that in patients with established heart failure, even if it's mild, that you could reduce diuretic therapy. They have an antihypertensive effect, and we've seen again that there's even been an ability to reduce antihypertensive therapy in these patients because of the salt-losing effect that occur in the kidney. So I think it's an exciting group of agents that we're only really beginning to explore all the benefits and applications. But heart failure, in all aspects of heart failure, I think they have really become a very important one to consider. I also think if you look at patients with non-alcoholic fatty liver disease, it's an area that we only really beginning to understand the risk and the risk of downstream cancer and complications with cirrhosis, that this is another area where these agents, because of the effect on the fat and the fatty deposition in the liver, that they have a beneficial effect there as well. There's been some recent data about metformin, for example, preventing atrial fibrillation, that patients had a lower risk of atrial fibrillation. That's another aspect of metformin that we haven't even considered. And then the thiazolidinediones, which we haven't discussed today because they've sort of been established treatment, have had a lower risk of dementia, whereas patients on sulfonylurea had a higher risk of dementia. So I think our movement away from the old way of metformin, sulfonylurea, insulin has really been challenged by these new agents, newer agents, and the different understanding of how diabetes works. And with heart failure itself, we know about the neprilysin inhibitor with the angiotensin receptor blocker and how that has really made an impact. And again, there are various options, and you have to again adjust the individual treatment. We know that the European Society of Cardiology have changed their approach. So it's not anymore a stepwise approach, but really to intervene on the level where the patient is and see what would be the most appropriate agent to use in that situation. So depending on the beta blockers, what diuretics, do they need a diuretic? Do the SGLT2 inhibitors come in earlier? Should they have a neprilysin inhibitor with a angiotensin receptor blocker? So our options have really improved. The corticoids, whether the patient can tolerate those, we have eplerenone available. And so each of these areas that have developed have changed how we approach these diseases. And we have to continue. That's why you are at this Congress, is to learn how to adjust your own treatment program and approach, because new ideas, new interventions, new understanding helps us to do a better job.
¿Alguna otra pregunta?
Sí, hay una pregunta adicional acá. There's another question, doctor, please. Once the therapy with these drugs is initiated, when should we look for HbA1c? When to measure these levels?
Yeah, so I usually give 6 to 8 weeks, but during that time, depending on what treatment the patient has been on, I do ask them to send through profiles so that I can see what their sugar levels look like. And I ensure that we don't delay any escalation of treatment. We know that the benefit shown, especially with the SGLT2 inhibitors, happened early. The diabetic control was maintained, and the same with the GLP-1 receptor agonists. The DPP-4s weren't as dramatic, but they also work well with metformin, and they may be a little bit more affordable. We've got agents, we've got patients on triple agents, for example, metformin, DPP-4 with an SGLT2 inhibitor. And usually I would give 6 to 8 weeks before repeating the HbA1c to see in what direction we are going. And I want to, by 6 months, I really want to have that level down to where we have targeted that particular patient. I'm sure you also know about the approach that was suggested by one author, that there are different phenotypes of our type 2 diabetics. So we have the older patient with mild diabetes. We have the patient with latent autoimmune diabetes of adulthood that need insulin from the start. And then we have this middle group that have obesity, insulin resistance. And for me, that is really where these agents can make a massive difference in the long-term outcome of diabetes. So yeah, I think that would be the area that I think they have the best efficacy, especially on the obesity, no hypoglycemia, but good HbA1c improvement.
Vamos a cerrar la sesión. The Peruvian Society of Internal Medicine is very grateful to Dr. Koch for your excellent talk. Thank you very much, Dr. Koch.
Thank you very much. Have a good Congress, and thank you again for the invitation. Enjoy. Thank you.